indications for this product are urgent, emergent, or medically necessary, okay? So very, very broad indications, but if you guys think about it, this product is a very safe, easy, and effective way to administer fluids and medications to a patient very, very rapidly. Not necessarily always for a code situation. Oftentimes you have patients with other kind of conditions that may require rapid access and they have poor vein structure. So we can use this, maybe an intravenous drug user who's having an OD. We can't get veins because their veins are totally messed up. We can use an IO to get fluids to them. Diabetic ketoacidosis, you got a patient super dehydrated, low blood sugars, trying to get sugars administered to them. We can use an IO for that. So if you guys kind of think about the scope of things that this can be used for, the indications are very broad. So anytime that you're having trouble getting a peripheral line or getting any sort of vascular access, we can use this product and get resuscitation to the patient very immediately. So there are 5 contraindications and they're very site specific. Those contraindications include if the patient has had an IO in place in that particular landmarked area within the last 48 hours, we want to avoid putting another IO into that same bone. And the reason for that is it takes about 48 hours for that bone, the hole in the bone, to heal up and close. So if we put another line in there and we put fluid under pressure, it's going to come out that other hole, okay? So if you think about that same train of thought, if that target bone has a fracture in it, we want to avoid going into that bone because if we put fluids in there under pressure, it's just going to come out the fracture line. Does that make sense? Another contraindication would be if you're getting ready to place an IO and you see a large surgical scar on that patient in that particular area. Let's make the assumption that they've had an orthopedic procedure. And what happens when you get an orthopedic procedure is typically you have some sort of hardware in there. A little stainless steel needle isn't going to go through a titanium plate. So if you see a large surgical scar, just go to an alternative location. If the patient is presenting any sort of infection in the area that you guys are targeting, whether it be hot, red, puffy, or even an open wound that's oozing or pussing, we don't want to put a needle through that because we could possibly introduce bacteria into that bloodstream. So avoid that area as well. And last but not least, if you're trying to target and landmark a particular area and you can't identify that bony prominence that we're trying to go into, let's go to an area that we can. So a perfect example is that maybe you've got a big bodybuilder and they're super, super buff person. They got a lot of muscle mass and you're trying to go into the proximal humerus and you just can't feel that humeral head. Well, bodybuilders, they always skip leg days, so we know we can go to the tibia, and we can actually probably find a bony prominence down there. So those are really the only contraindications for this product. Notice I didn't mention anything about like osteoporosis or any sort of poor bone quality. Obviously, when you guys have a patient out in the field, you can't look at them and know what their bone quality is like. This product is designed, the needle is specifically designed to cut through bone. So it makes a very precise hole into the bone, and it allows for that catheter to fit in perfectly snug, okay? Doesn't cause bone fractures. We don't have any known incidents of ever having any sort of any sort of problem like that. So any questions on the indications and contraindications? Excellent. So we're going to talk a little bit about landmarking, the different sites on the human body that we can place this, and a little bit about adult and pediatric. So on an adult patient, we have 6 locations. We go to the proximal humerus, the proximal tibia, and the distal tibia. And I'll go over landmarking on these areas in just a minute, and we'll kind of do it a little interactively. But of those sites, the best place to put this into a patient is going to be the proximal humerus, and there's a couple reasons for that. So number one is that when we go into the proximal humerus, we can put 6.3 liters of fluid per hour into that patient, okay? When we go into the legs, it's more like a liter per hour. So if you think about the significance of that, it's either a liter an hour or a liter a minute. So we can get a lot more resuscitation to a patient going through the proximal humerus. Reason for that is because it's a non-weight bearing bone, so it's very porous. The medullary canal in there is a lot larger, so it just has a lot better fluid rate, whereas weight bearing bones are a lot more dense, so that medullary canal is going to have a lot more dense qualities to it, okay? Second reason why this is such a good area for you guys to go into is because of proximity to the heart. We can actually put fluids in here, not only going to get that huge high flow rate, but it takes about 3 seconds to process. If they put a central line in the ED, they typically are taking that out within 24 hours because it's considered a dirty line. They don't want to leave that in there. But if we send them into the hospital and they have a proximal humerus IO, and we have good flow, they can keep that in there for 2 days, which gives them the ability to get them up to the ICU, open that sterile field, and go through that methodical process of putting a central line in, and then that central line can stay in for up to 7 days typically. So a very, very important thing to remember, it's a bridge to a gap. Now with adults, 21 years and older, it's 48 hours dwell time, and your pediatrics consider 21 years and younger, and that's 24-hour dwell time. So you guys have a significant amount of time that this can last, okay? The third reason why the proximal humerus is such a great spot is because for a very first time user of an IO, on their very first attempt going into the proximal humerus, you have a 97% success rate, okay? So think about that, you've never used an IO before, that's such a small window of failure, you guys are gonna hit the right spot pretty much every time, okay? So the only other thing I want to talk about as far as areas on the body we can go into on a pediatric patient, and we typically would say 15 or younger, and the reason for that, I mean, IO 21 and younger is pediatric, but we could go into the distal femur, and I'm going to talk about landmarking that here in a minute as well. The distal femur is a great spot when you think about when you have most of your pediatric patients. This is a tib fib of a pediatric. I mean, that's an extremely small target to try to hit. The femur is the largest bone in the body. So when you get those really tiny little patients, you're going to have a lot better success rate going into the proximal, or the distal femur, sorry. We have studies that indicate going into the distal femur on a pediatric patient, you have a 99% success rate on your very first attempt, if you're a very first time user of the IO. So pretty significant that you guys can get that spot and have success and get a good flow rate. So I want to talk a little bit about landmarking the different sites, and I'll start with the legs. This is going to be your least common opportunity. As I mentioned, the number one spot you want to go into is proximal humerus. Okay, so it would be kind of 1, 2, 3 on your adult patients. On pediatric patients, a little bit different. We want to try to go proximal humerus if possible, but your patients from the age of about 7 to 9, it's really hard to landmark that area just because their bone's not fully formed. They're very, very tiny. So in that situation, in that age group, we probably want to just start with the femur. Okay, does that make sense to everybody?
So you're saying femur is best from 9 years?
7 to 9.
9 years.
9 years and younger. Yeah.
Okay.
Yeah.
Yeah.
So, so does that make sense to everybody? So when we landmark the, I'll just start from up here and go down. But when we're landmarking the proximal humerus, and this is going to be one that you guys are going to start adapting. Is that correct?
We have it now, but it's just not.
So what we want to do, most importantly, with the proximal humerus, we have a biceps tendon that's in here, and as you move your arm around, that bicep tendon kind of floats around over the humeral head. So the risk of that is, it doesn't really matter if you stick the needle through that, but if the arm moves around, it's going to try to eject the needle. So most important thing we want to do is try to get that biceps tendon out of the way before we place this needle. So we achieve that in 2 different ways. Number one, we can put the patient's arm right across their belly, and that rolls that tendon right into their axilla, so it's out of the way. So all we have here is soft tissue and bone, okay? But this isn't always very achievable, especially if you guys are using Lucas, or you've got a pregnant patient, their arm would be way out here and it kind of bundles up that tissue, or you just have a guy with a big beer belly, right? So we got the arm kind of far away, so it's not always that achievable. So what we recommend is you actually take the patient's arm directly to their side, and we're going to turn their thumb posterior, okay? So I always say thumb to the bum. And the nice thing about this, when your patient's laying flat on their back, if we put them in this position, you can even tuck their hand up under their butt and it kind of stabilizes it. But as you can see, her proximal humerus kind of punches out right here when I put her arm in that position. So it makes it really, really easy to identify, okay? So we're gonna go hand to the side, thumb to the bum. And now what you guys can do is just open your hand like this, and you're gonna see your palm has a very, very concave aspect right here. We're gonna use that as our humeral head finder. And so I can actually come into her and just start palpating around until it kind of fits like a Lego, where the most proximal aspect of her, or the most prominent aspect of her humeral head is right in tune with that concave aspect of my palm. And I'm gonna find that this spot is gonna be right about here on her. Okay? Does everybody see that? And we'll let you guys practice on each other. Another way that you can identify that area, and I always talk about using your karate chops. So we're gonna have our hands like this. I'm gonna take one hand and just put it right in her axilla, okay? I'm gonna take my other hand and put it right at the midline of her humerus. And now I can bring my two thumbs together like a triangle and drop them straight in. And you guys will notice that puts my thumbs just right in line with where her humerus is. And now I can start palpating up until I feel a notch right here. It's kind of a step up. It feels like a golf ball sitting on a tee. Once I identify that, that's right where the surgical neck and the humeral head come together. I can actually landmark about 2 centimeters proximal to that, and it's gonna take me right to that same location. So I think when you guys start doing these more frequently, you'll get really comfortable where you can just actually kind of landmark it here. And now remember, when we're going into the proximal humerus, that's a huge target right there. We're not shooting, we don't have to get a protractor and a ruler and try to figure out this spacing and everything. We're going for a pretty big size. It's almost the size of a quarter. As long as you're somewhere in the middle of that, you're going to the right spot. Does that make sense to everybody?
So we're doing thumb to bum there. So
Thumb to bum.
now when we are putting our hand across our tummy, the head, is it going to change positions?
It's not as pronounced when it's here. As you can see, when I turn it like this, it kind of pushes it out. But that area is still the same area. Okay? Does that make sense?
Yeah, it does make sense. I'm just.
So remember, we're dealing with a bone, which I call a non-collapsible, non-rolling vein. It's a permanent structure in there. We can palpate pretty hard in there to find that area that we're going into. But when you have your arm across the belly, I'm still going in right here. If I have my arm across here, it's still the same spot. It doesn't really change the bone. Just when you put your arm to the side, and it just kind of punches it out a little bit like this. So it's just a little easier to identify. Does that make sense?
Yes.
Okay. Now, one thing I want to talk about too is you guys are using a Lucas machine. After we've positioned the arm and we've put the needle in, it's okay for the arms to move. The thing that we want to keep from happening is for their arms going any higher than this. Okay? If we get their arms, so we're going to strap them to the Lucas. After we've positioned the arm and put the needle in, we've had that axilla, we've got that tendon out of the way. If we put their arms up like this, it's not going to be, detrimental to that IO. But if the arms get above their head and start moving, these muscles bunch up and that tendon starts floating back and forth. It's going to try to eject the needle or bend it. So really important to remember, especially with the Lucas, I think the arms go right about here. They're still well below my shoulder. It's going to be an okay position. Just make sure it's positioned properly before you insert the needle. Any questions on that? Perfect. Okay, so remember, number one spot, proximal humerus. Best flow, quickest to the heart, easiest to achieve, okay? So now in adult patients, when we start going lower, we can use the tibia, which I know you guys are all familiar with. A lot of people talk about using the tuberosity as your landmark. We talk about using the patella as your landmark. It's a little easier to find, especially even on little tiny babies. They have a little tiny piece of cartilage in there. They may not have a fully formed patella, but they do have some sort of patella in there. And so this is going to be your better way to landmark them. On your pediatrics, that tuberosity hasn't fully formed oftentimes. So we're going to use the patella. And on your adult patients, you're going to go to the most distal aspect of your patella, and you're going to go about 1 to 2 centimeters distal and about 1 centimeter medial. Remember, we always go IO, big toe. We're going to go on the medial side. So we're going to go right into the area right here. Okay? On your pediatric patients, it's going to be about 1 to 1.5 and about 1 over, just because they're smaller anatomy size. Does that make sense to everybody? Okay? On the distal, you're going to find the most prominent aspect of your medial malleolus. It's going to be that bump that you knock on a coffee table when you walk by. You're going to go about 2 centimeters proximal to that and go straight into the bone there. But remember, this is going to be the furthest from the heart, and you're getting only about 1 liter per hour. Okay? So now when we talk about on a pediatric patient, if we decide we're going to go into the femur, as I mentioned, your tibia is tiny. Trying to hit that spot is going to be really small, especially in your smaller patients. So we can utilize the femur, which is the biggest bone in the body, and what we're going to do is we're going to have their leg extended again. We're going to identify their patella, and we're going to use the same landmarking technique, but we're going to go proximal to the patella. So we're going to go about 1 to 1.5 above the patella, and then about 1 centimeter medial. And we'll just go into that medial condyle. Does that make sense to everybody? So really easy. As I mentioned, pediatrics we consider an IO 21 and younger. We try to keep this spot down in the femur for your patients that are going to be 15 or younger. Obviously that 9 and younger is going to be your prime target for that. And the reason for that is because as patients get bigger, their quadriceps, that soft tissue, is thicker. And you know, you get like a 17-year-old boy that's got big legs, even our longest needle may not be able to get through all that soft tissue and through the bone. So it's very, very patient specific, and you guys have to kind of use your judgment in the field, you know, when you're identifying how much soft tissue is there, okay? So now I'm gonna go back, just wanna talk a little bit about when we place the IO into a patient. Anytime we're going into the legs, we're gonna go 90 degrees to the aspect of the bone, okay? So you're gonna find that landmark area and you're gonna drill straight in. And we're gonna drill in until we feel a loss of resistance, and we'll just stop drilling. We know we're through the cortex and into that medullary space. When we go to the proximal humerus, we're gonna follow the rule of 45s. And this is a really important thing for you guys to understand, because it's also gonna be very helpful when you have a lot of activity going on at the head of the bed. You've got people managing compressions, you've got people managing airway, you've got people trying to hook up monitors and lines and all this stuff. There's a lot of activity up there. So we're gonna follow the rule of 45s, and what I mean by that is when we go into the proximal humerus, after we've landmarked that target area, will you come up here? I'm gonna be able to show instead of trying to do it on myself. So when we landmark that area, we wanna go at a 45-degree angle from their head, and then about 45-degree angle from the bed, okay? So really what I'm looking for is I'm trying to achieve is if that person had an imaginary seatbelt on, that's kind of the line that we're gonna go. And we're also gonna go from anterior to posterior. So what we're doing is we're aiming for the opposite hip pocket. Does that make sense to everybody? So when I go into her, I'm gonna go at about this angle right here. Okay? And we'll drill straight in. Now, just to show you guys what that means is like if we're in a code case and you've got somebody that's over here doing compressions or hooking up a Lucas or whatever, we've got somebody up here that's managing airway, what we can do is approach the patient at a 45-degree angle. We've already established our line of trajectory, so we know we're in the right spot, but I'm kind of in no man's land right here. There's nobody here, and I'm not gonna interrupt anybody that's working on that patient. I can come in and actually identify my target area, I can place it, put a dressing on, flush it, and have it going in 10 seconds and be out of the way. So very, very achievable, even with all that activity at the head of the bed. Does that make sense to everybody?
The last 45, that was from the
So-
inside forward.
So if we look at this little guy, I'm gonna go 45 degrees from the head, and then about 45 degrees from the bed. Does that make sense to everybody? So we're going anterior, posterior, in that imaginary seatbelt line. Any questions on any of that? So I kind of ran through all that landmarking stuff pretty quickly.
The humerus, were you gonna talk, the femur, you go parallel to the floor?
You go to 90 degrees to the aspect of the bone.
So if you have the leg flat out on the floor, your needle's gonna be going parallel to the floor?
Let's see.
Which one are you looking for?
Look at this little guy.
Your muscles are mostly- Yeah.
So on this little patient, I'm gonna go about 1 centimeter above the patella, and then about 1 centimeter medial. We can just go 90 degrees into the
90,
bone now.
okay, so not sideways, up, down,
Yeah,
okay, perpendicular.
Yep.
Okay.
does that make sense? Okay. Perfect. So, and we're gonna practice landmarking on each other. I've got bone blocks and everybody can drill into. We'll do a little hand-on exercise here in a minute. So is there any questions on landmarking, on positions, age categories, anything like that that I've covered so far?
The age range for the humeral head.
Humeral head is anybody and everybody. Typically, your patient's 9 years and younger. It's gonna be difficult to landmark that area because their bone formation isn't completely there. So typically 9 years and younger, I would try to defer to the femur.
Same question on that, on the distal femur.
Distal femur, what we said with the distal femur is patients from 0 up to about 15 is where you start getting into that age range where the
bottom
soft
of the
tissues are
ceiling.
developed, that it's very difficult to achieve getting through the cortex there.
So if you can palpate your landmark, that's good.
Yeah, if you can feel your landmark, you can go for it, okay? Any other questions on that?
Because the fever is important when you line it up to have the foot perpendicular to make sure you get the right landmark.
Typically, you want to have the leg extended in full extension and try to keep it perpendicular when you're landmarking it.
So toes towards the ceiling?
Toes to the ceiling. Good question.
Some people, we found at a cadaver lab last week as well, they found it to be easier placing when they were on the opposite side
Opposite side.
of the table from the leg they were placing in, if that makes sense. So like if my patient was laying here, their two legs, I would place in the leg that's not closest to me. If that's
Opposite leg.
opposite from the
Because we're trying to achieve that medial side of the bone. So being on the opposite side gives you a more direct shot at that bone. Whereas if you're trying to do a leg that's close to you, you're kind of coming back towards yourself. Okay, remember we always go medial side, IO big toe.
Mhm.
Any other questions on any of the stuff that we've covered so far? Okay, perfect. So I'm going to jump into a little bit about the device and kind of the supplies that you guys have, needle sizes and things like that. So first and foremost, I'm going to go through the needles, and I'm going to actually just pass a couple around for you guys to take a look at. But when you remove the needle cap, I'll let you guys kind of take a look at that and pass it around. I call it a needle set, and I'm very specific about that for a reason, because it is a set. It has a cap, it has a stylet, and it also has a catheter. So it's a 3-part device. Very important to remember, but if you take the needle cap off, you look, the actual catheter has black lines around it. The stylet does not have any black lines on it. And those black lines are intended for 2 purposes. Number one is to make you guys recognize that you do have a catheter in place before you insert this into a patient. And I'll explain a little bit more about that in a second, but the second reason those black lines there is they work as a depth gauge. So after you've pushed through the soft tissue down to the bone, we want to make sure that we at least identify one black line above the soft tissue before we engage the driver. That gives us the reference that we have at least 5 millimeters of depth so we can get through that cortical bone, okay? And I'm going to actually stick my needle sets into a bone block here and just kind of walk around and let you guys take a look at what I mean by that. So when I push down to hard bone, you guys can see with the pink one, I don't see a black line. So that's not going to be long enough to get through that soft tissue and get in there. But if you see on the blue one, you still see at least one black line above the soft tissues. That means that that needle and catheter still have enough length to get through the cortical bone and actually get to the medullary space. Does everybody see that? Okay, perfect. So, and the reason that it's very important for you guys to recognize the black line showing that you have a catheter on there is I see this happen frequently, is that somebody is in a situation where it's a code case, they're in a hurry, we're getting this loaded on the driver, and they pass the driver off and they've taken the needle cap off, but you guys notice, I took the catheter with me. I didn't slide the needle cap off, I actually twisted it off. So if you ever are handed a driver and you see a needle set on there and you do not see black lines, do not engage the patient. Because if we put that in the patient, we're going to drill a hole in the bone, and that stylet doesn't have a hole in it, doesn't have a catheter, there's nowhere to put fluids or anything. So now you've got a hole in the bone that's going to be impossible to replicate. We're going to have to go to a different site, landmark, and redo it. That's going to be considered a failed IO. Okay? So very important to remember, when we load this on the gun, first and foremost, it's a very light magnet that it sticks on so it doesn't fly off when you're moving around. But when we're going to take the needle cap off, I always say cradle the gun and hold on to the actual needle set, slide the needle cap off. Always make sure you see black lines there before you engage the patient. Okay? Does everybody understand that? Perfect. So, I'm going to jump back a little bit. You have 3 different needle sizes. You've got they're all 15 gauge, so they're gonna have the same flow rate depending upon what bone they go into, okay? They're just different lengths to accommodate different anatomy, different tissue thicknesses. So the pink needle that you guys have is our 15 millimeter needle. It's indicated for 3 kilograms up to 39 kilograms. So you think about that, it's like what, 39 seconds?
It's 80 pounds.
80-pound patient, it's pretty small, right? This is like, and I know we don't say that we have a pediatric needle, but I always kind of say pink pediatric. If you're going into a really small patient, this is gonna be the target that you use. Typically, your really tiny little patients. The next size we have is a 25 millimeter. It's also 15 gauge, as I mentioned. This is indicated for 3 kilos all the way to the moon, okay? And then your longest needle, which is the 45 mil, is actually indicated for 40 kilos and up. So the way I always talk about these needles to really simplify it is pink is gonna be pediatric, your little tiny patients. Blue, like the ocean down below, if you're going into the legs, this is gonna be the needle choice for pretty much 90% of your patient population, okay? And then yellow, like the sun up above. If you're going into the proximal humerus, this is gonna be your needle selection. So, real easy. You guys are in a code situation, and you guys decide I'm going humerus, grab a yellow kit. If you're gonna go into the legs on an adult, grab the blue kit. If you're going into a pediatric patient, typically you're gonna go with the pink, okay? Any questions on that?
Okay. Something with the needles as well, with Chris touching on the black lines always having to show, with those weight ranges, is the blue needle can be used on pediatric patients as well, because if you have a tiny baby that has initial entire legs, sometimes that pink needle is not gonna be long enough to make it through the extra tissue.
Yeah. And
Have you seen like, cause sometimes little babies, let's say you have a 6-month-old, they got those fat little legs.
Yeah.
I don't think just eyeballing it, the pink is probably.
may not
too
fit,
short.
especially going into the femur.
So blue is probably
Blue may
the
be
same
more
thing.
appropriate, especially if they've just got those chubby little legs, yeah.
And again, that weight range is 3 kilograms and above, so it can be used on the pediatrics.
But that's the beauty of that, being 3 kilos all the way up is pretty much, it's gonna work for any patient population the pink needle will work for, but it's gonna give you a lot longer length for tissue ranges, okay? And we'll talk about when we insert these too. It doesn't matter really if you're using a pink or blue on a pediatric patient, it's the placement. And I'll get into that in just a second. So, I'm just gonna kind of walk you guys through application of these. You're gonna take your needle set, you put it on your driver. Make sure you cradle the gun and hold the actual hub. Slide the needle cap off. We're always gonna make sure we see black lines here, okay? We've landmarked the patient, and so now what we're gonna do, let me use this one, look. We're gonna actually, without touching the trigger, we're gonna insert this into the patient, and we're gonna push through the soft tissue until we hit a hard stop on bone, okay? And just to back up a little bit, putting one of these in is about the same pain on a patient, if you got an alert and conscious patient, as putting a peripheral IV in. It is a 15 gauge needle, so it's a significant pinprick, but it's pretty much similar. You're gonna be putting a peripheral IV in somebody anyway. It's gonna be about the same pain threshold. So we're gonna push down until we hit hard bone, okay? Once we hit the hard bone, we're gonna make sure we see at least one black line above the soft tissue. At that point, we know that we have enough needle length. Now we're gonna engage the driver. The important thing to remember, this is easy IO, not aggressive IO. We're not using it like a DeWalt drill. We're not trying to drill through a fence post or something. We're gonna let the needle that has that cutting blade that I talked about on it, and just the weight of the driver do all the work for us. So we're gonna actually activate the driver until we feel a tactile loss of resistance. So you're gonna feel resistance when we're going through the cortex. The minute you feel that loss of resistance, you can let go of the trigger. We don't wanna recoil or anything like that, just let go of the trigger very gently. So I'll just demonstrate here. See how it starts to sink when it gets through that cortex? I just let go of the trigger. Now I can hold onto the hub, lift the driver right off, and now we can actually take the stylet out, and we'll put it in our little sharps container. All of your kits have a little sharps lock in there. It's great for you guys in the field. You stick it in there, it doesn't come out, it can get kicked across the room. Nobody's gonna get poked. We put the stylet in there. The next thing you guys are gonna do is get your stabilizer dressing, okay? These are I think your guys' kits, you have these separately. These are really important to use. They stabilize the dressing, they protect it, they keep that needle from getting dislodged or bent or broken off, okay? The other thing that I wanna point out is it actually has kind of a little telescoping mechanism in it, okay? Notice when I put this needle into the patient, I get through that cortex, I didn't put that hub all the way down to the skin. We're not trying to get the hub to the skin, we're trying to get the needle and the catheter through the cortex into the medullary space. So if that hub is sitting high, it doesn't matter, that's why that dressing is designed to telescope like that. So we can actually take the dressing, we're gonna put it over the hub and push it down to the skin. Now you can remove your 1 and your 2 and stick down that tegaderm. Once we've done that, we're gonna get our little extension set that also comes in your kit. Hook that to a sterile saline flush. Be sure and prime it before you attach it to the device. And now we can hook it right up to the hub. On your adult patients, we're gonna do 5 to 10 mils of fluid, and it's a rapid flush, okay? It's important, the mechanism for this rapid flush is to get all that marrow and all that stuff that's inside the bone out of the way so we have a pathway for our fluids and meds to go in. So we're gonna do 5 to 10 mils of rapid flush, okay? On your pediatric patients, it's gonna be more like 2 to 5 mils, okay? Any questions on that? Once we've done that rapid flush,
That, just so they know, that hurts.
yep, and I'll jump into that here in just a second. So after we've done that, you can take your syringe off, and a lot of people don't know this, but the dressing has a great little clip on there, so you can put your extension set on there. Once this is inserted, this can be used for anything that you would put through a peripheral IV. Okay, same rate, same dosage, all that kind of stuff. Anything you put through your peripheral IV can go through this. I did put some pamphlets on the tables here, little pocket guides that have drug references that tell you everything that's compatible with the IO. Okay?
Blood can go through that too.
Yes. Whole blood products go through here as well. Remember, it's a 15 gauge as well, so it does have some significant flow. Okay? So, going to the point that he made, when you flush, so I was talking about the pain threshold. When we put it into the skin, it's going to feel like a pinprick. When we drill into the cortical bone, there's no nerve endings in that cortex. So when we drill through the bone, it's not going to hurt. Okay? They're going to feel that pinprick. That's what they're going to feel. They're not going to feel anything drilling into the actual cortex. Okay? But when we have an alert and conscious patient, and we do that rapid flush, the inside of that bone, this cancellous bone has a ton of nerve endings in it, and it senses that change in pressure, and it can be pretty significant. Like, you have an alert, conscious patient, and you flush them, they'll jump off the table. They're gonna feel it, okay? So in that situation, we can actually use lidocaine, and we're gonna do that in a manner where we've inserted the needle, we put the catheter in, we've removed the stylet, we put the dressing on, and now we can actually administer lidocaine before we do the flush. Okay? This is very time dependent. So if you're in a code situation, a very emergent situation, sometimes you gotta hurt them to save their life. But if it's in a situation where you can slow things down a little bit, and we can administer lidocaine to reduce the pain the patient feels, then we'll use lidocaine. So what we're gonna use is the 2% epi-free, non-preservative. Typically, do you guys have the cardiac lidocaine? And it's preloaded syringes in the pink box. So that's the lidocaine of preference, okay? And what you're gonna do is actually hook it directly to the hub, and you're gonna do 2 cc's over 2 minutes. And I'm talking like real 2 minutes, not emergency minutes, okay? Because if we put it in too rapidly, it's gonna hurt. There's no point in using lidocaine, okay? So we're gonna let it trickle in over a 2 minute period, trickle. Once we've achieved putting that entire dosage in, we can actually remove the syringe, and now we're gonna let it dwell for 60 seconds. And my other joke of the day, we're gonna let it marinate in the bone, okay? So it's really important to let that 60 seconds, when you think about when you get a filling at the dentist, they don't give you a shot of lidocaine and then just start drilling on your tooth. They go have a cup of coffee and let that stuff kick in. So when you think about the significance of this, in an emergency situation, if we're gonna use lidocaine, we're adding additional 3.5 minutes to the process. So if it's important to reduce the pain for the patient and you have time, this is a great alternative. If you don't have time, like I said, sometimes you gotta hurt them to save them, right? Any questions on that? So on a pediatric patient, you're gonna use 0.05 over 2 minutes, and then you're gonna allow the 60-second dwell, okay? If we ever have a situation where you're transporting a patient, you've got an IO flowing, you've used lidocaine, they start complaining of pain again, we can unhook the extension set, we can re-administer lidocaine, you're gonna use half the dosage over half the time, 60-second dwell, and you can hook the line back up, flush them, and get them going again. Typically, you guys probably won't see that very often in the field, right?
And, in my experience, the more room temperature on the slightly warmer side of the fluid is, the more the patient's fine.
Yeah, that makes sense, kind of like a nerve sensitivity, like with a tooth when you drink something too cold or whatever. So, one thing I will point out too is, once you get it flowing, and it's been going a little bit, those nerve endings, you know, kind of get desensitized to the fluid going through there. So typically, if they do feel pain when you put it in, it's gonna subside a little bit. It varies from patient to patient. So any questions on any of that so far? Yes, ma'am.
We'll probably get the question on why the sternum is not a preferred site. Do you have reasons why we don't go there?
So from what I gather, and I think that the sternum, that placement was actually kind of invented in the military. And when you think about in military situations, combat situations, their job is to stop the bleeding and get fluids in and get them out of there. They don't resuscitate, they don't do compressions, they don't do anything like that. The sternum is a great shot, they can boom and shoot it in, pack their wounds and get them out of there. I don't know, you may have some more insight on that.
I was just reading the pamphlet and it said no to the sternum, and we get that question.
Yeah.
And I didn't know if there was any evidence behind it. It seems to me like if you go too deep, there's a lot of great vessels.
There's
a
a
sternum there.
There's a lot of stuff underneath there, and if you go too deep, it can be significantly dangerous. And as I mentioned, like the military uses it as like, this person's gonna die if we don't get fluids and stop the bleeding, but they're not gonna do anything else. They're not gonna sit there and do compressions and try to revive the patient when they're getting shot at. So they're just doing what's easiest and getting them out of there. With our product, it's contraindicated to be used in the sternum, so don't ever try to place one there. As I mentioned, as she mentioned, there's a lot of stuff underneath there that could be very, very dangerous if you go too deep.
Well, that's we're in P school, right, Eli? And we can do whatever we want.
I just know we'll get the question and it's like,
Yeah, and it's funny you say that, because like every one of these kits, when you open them, you'll see a little package, a little insert that comes out. It's got a picture of a sternum with a big silk across to it. Okay?
I was showing them this, we have this fast interosseous infusion system. This is the one that you're talking about. I don't know why, people can random stuff.
It's been in there since
Yeah.
1982 or something.
It's just, we're just gathering stuff, you know.
That's the medieval device.
It's a very good, it is really
Yeah,
good.
I've never even used it, I don't know anything about that.
So,
Scary.
I
Yeah.
So just one thing I wanna kind of touch base on, you guys have these yellow kits. All your packs, the way that you guys get them, it's gonna be a peel pack that has your needle set. It's gonna have your little pink bracelet. It's gonna have your sharps, and it's gonna have an extension set, okay? And then you'll have a separate kit that has your stabilizer dressing in. Hopefully, and I think you guys do, have everything that you need in this bag. The additional items that you're gonna need is gonna be some sort of skin prep, and then your sterile saline flushes, okay? So, if you have that stuff all in that bag, if you need to place an IO, you grab that yellow bag, you should have everything that you need, okay? So, to touch base a little bit on this pink bracelet, I mentioned that a adult patient, we can leave this product in for 48 hours. On a pediatric patient, it's 24 hours. You guys are typically getting your patients, transporting them, and passing them off to higher level of care, right? It's very important that when you guys place an IO that we put the date and time of placement on this bracelet. So if they go to the ED, they go to the ICU, as they go on through their continuum of care, everybody knows when it was placed, so we know when it needs to be removed, okay? The other really nice thing about this pink bracelet is that there's an 800 number on here, and we have clinical staff, nursing staff, manning this phone 24/7. If you guys ever have any questions about insertion, removal, meds that you're putting through, blood draws, anything like that, you can call these folks and they can walk you through any sort of questions that you guys have. So this bracelet I know goes unused probably 90% of the time in most facilities I'm in. I'm just reiterating, guys, this is really important. It's giving people information on when it was placed, so when you're not there anymore, they know when they have to get it out, but it also gives you a tool right there. If you ever have any questions, you guys have a resource right there, okay? So the last thing I want to cover, and you guys probably don't very frequently ever have to remove this device, right? You guys pass them off typically, okay? If there's ever a situation where you have to remove the device from a patient, most important thing to remember is we're going to take the extension set and the dressing off. Most important thing to remember is that we do not ever want to rock back and forth with the hub. We can use any lure lock syringe that you guys have, attach it directly to the hub, okay? Now we've got a removal tool, right? So what I always recommend to people is that you turn your hand upside down like this, grab onto the hub with your finger and thumb, and then you can wrap the rest of your hand around the syringe. So now you got a handle to extract it, right? Do not rock back and forth. There's been instances where people have broke the hub off of the catheter and now you've got a piece of metal sticking out of the bone. We gotta get a surgeon to retrieve it. It's a mess. So do not rock back and forth. What we wanna do is put counter pressure on the patient and pull straight up and out, okay? If it's ever really bound up and you're trying to get it out and it doesn't feel like it's coming, the catheter still has a little bit of those cutting teeth on it. You can actually 10 and 2 a little bit. It's okay to twist it back and forth from the hub just to free it up, but we just want to pull straight up and out. After we've removed it, you can put a Band-Aid over the skin. It's not like a vein where it's gonna seep and ooze and leak and stuff. Put a Band-Aid over there, it's gonna protect that little insertion site. The bone's gonna heal up on its own within 48 hours. Any questions? All right, well you guys are awesome. So now you're all IO pros. I've got some bone blocks. I've also got some eggs, and I want you guys just to come up and get a little hands-on of using the needle and driving it in, just so you can kind of sense that tactile. I'm sure you guys have all done these before.